Okay, so the content in this section under is some highlights from development and course of substance medication-induced disorders. It's a little bit of overlap with what we already looked at under the substance-induced medication mental disorders section just above you or on the last page. In the video that accompanies that. So I'm going to try not to repeat myself here. So I'll just try to pull out some things that are specific, uh, or not what we already discussed above about the challenges of trying to differentiate between is it a substance use disorder primary, or is there a mental health condition, mental disorder condition that is primary, and the substance use is a byproduct of that. So, one of the things that's practically helpful for us as a guide from the DSM is the general guidance of okay, well, the 1 month marker. So, if a person has symptoms, the way the DSM writes it, that if a person continues to have either by report or by your or others' observation, have symptoms associated with another mental health condition um, beyond 1 month of last intoxication or the end of, and they specifically say acute withdrawal, um, that that gives you at least some guidance around, well, this may be more of an independently existing diagnosis independent from the substance use. So the 1 month marker as a help for that. It's certainly not a clean, okay, it's been 31 days, so it must be this for sure, for lots of different reasons. One, non-severe intoxication or even social use that doesn't meet criteria for intoxication, I think, can be a contributing factor that you have to take into account as best you can, and that withdrawal can linger for long after that most acute phase, and maybe not be acute, but be very bothersome to the person. Um, but the 1 month does offer us a guide to work from for sure. Um, a couple things that, in terms of things to look for when you're like, okay, is the substance use a byproduct of another health condition, mental health condition or a mental disorder, um, is to think about self-medicating or limited or impaired self-control. So what do I mean by that? When people are in emotional pain and distress from depression, for a depressive disorder, from anxiety, or if they've sustained traumatic psychological injury, they're in pain or in a discomfort and duress, and sometimes that discomfort and duress is felt physically as well as psychologically. And particularly when if they don't have access to treatment or they're treatment hesitant for whatever combination of reasons, substances where they can feel at least temporarily better pretty quickly become very, very attractive as a means to cope. And so we call it self-medicating. The other thing is that the substance use can be a byproduct of impaired self-control. When we look at a manic episode, one of the hallmarks of a manic episode or a hypomanic episode is sort of lower governance, self-governance, and somewhat of a specific craving for substances, and a lot of times in the case of a manic episode or hypomanic episode, stimulating substances. Um, so that can be also a byproduct of limited or impaired self-control. That is a symptom of the mental disorder or mental health condition that they're experiencing. And then, of course, that influences behaviors and other symptoms, and can make it very challenging for us. But just thinking about those concepts of people will self-medicate is a very human thing to seek relief from pain, particularly quick relief from pain. And there are many of the conditions that or diagnoses or disorders that we look at where there is genuine limited or impaired ability to self-control and self-regulate and self-govern. Um, so a couple other things down here about why these distinctions are important. Well, the more and more, at least in the current trajectory, and this is maybe something I'm sure I've touched on in other videos, particularly at the beginning of the course. One of the reasons why doing good, sound diagnoses and really following the process of assessment, diagnosis, case formulation, treatment planning, why that is so important is more than ever, you guys as social workers are going to be um, your input on what you're observing and what your diagnostic impressions are going to influence prescribers who are not necessarily psychiatric specialists. And so, in many different, obviously, in primary care settings, that can be probably the most frequently occurring, but there can be other settings too. Um, and even for psychiatric specialists, you're getting more time with the client in almost any setting than the prescriber is. So your impressions are very important. So trying to tease that out can be helpful to the prescriber. That's what the book is telling us in these lines here. The other thing is to know that for most times that if someone has a pre-existing condition, and what do we mean by pre-existing condition as context? Someone has what appears to be a chronic depressive disorder condition or a chronic anxiety disorder condition that they have appeared to have had from early on in their life. Was it because of genetics? Sometimes we have that data to know, like, hey, there's more readily available genetic testing where you can make some inferences about that, or you just like, hey, I don't have the access to sophisticated genetic testing to prove this, but when we follow the client's report and the observation of others and previous medical records, hey, they've got a long-standing history of an anxiety disorder, depressive disorder, as examples. Um, Also, a person who's sustained a traumatic psychological injury. And even if they don't meet criteria, and we'll talk about this a little bit more on trauma and stress related disorders, even if they don't meet criteria for a condition like post traumatic stress disorder, um, just having sustained that psychological injury through a singular traumatic event or a series of ongoing traumatic events can make them more susceptible to substance use. So, as an example, if I am working with a client, and can be of any age, but for the sake of this illustration, a young client, an 18-year-old client who has been accepted to a college and is going to go live on a college campus and attend college, which is wonderful in most circumstances, that they've earned the ability to do that and they have the access to means to do it. Those are good things. Um, but I will say to them, so someone who has a known history of a depressive disorder or a known history of anxiety disorder, again, not exclusive to those types of conditions, but just using those as an example. Or I've been working with them on trauma recovery, recovering from a traumatic injury or a series of traumatic events in their lives. I will say to them, you have a pre-existing condition in which you have to be much more careful about your intake of substances than someone who doesn't have that history, doesn't have those pre-existing conditions. Sometimes to help people understand that, I will say if you are type 1 diabetic, and increasingly we see more type 2 occurrences of type 2 diabetes in younger people, as you probably know. If you're a diabetic, you have to be very careful about what you eat. What you take. Well, anything you take in. And what you take in for food and you know liquid substances. So, alcohol or otherwise. So it's somewhat of the same thing. A person who's a type 1 diabetic and has been dealing with that all or most of their lives, they're headed off to college. They can be very thoughtful about what they're going to have access to, and they may have less control over their what food is available to them than they did when they lived at home with a supportive family. Um, so likewise, with someone who we know has a history of depressive disorder or an anxiety disorder, or has sustained a traumatic injury, they want to be careful about abstinence is probably best, but really the message is about just being careful and being mindful when you make decisions about even social use of substances, that you may are more likely to have an adverse reaction than someone who doesn't have those pre-existing conditions. So that's just how I, as an example of how I might, share that uh, kind of information with a client. So again, hope that is helpful, about, in terms of the spectrum of this pretty bigger picture of how do you differentiate between, is a mental health condition, a mental disorder primary, or is it a substance uh, use problem that is primary?